Good afternoon, everyone. Thanks for joining us. We have an interesting panel discussion by experts from our country, our own country, and from the UK and Italy. And we will be discussing on how to stay functional in the midst of a pandemic. And over to Dr. Sanjeev Sharma, the President of the Society for Emergency Radiology, for welcome remarks.
Hello, everyone. It's a great pleasure to welcome all of you once again. And continuing from where we left the last time, so we had a very vibrant webinar, very well participated webinar recently on the radiology of COVID-19, wherein we discussed the various protein ways these patients could present and how the imaging features could look alike. So carrying on from where we left the last time, the bigger challenge is to manage the department, the equipment, as well as the staff, and how to stay functional in these trying times. So this panel discussion is going to focus on these two important aspects of radiology departmental management. And it's a great pleasure to welcome a very learned group of panelists. We have Ram from UK, we have Rafaela from Europe, we have Anju from LNJP Hospital in New Delhi. We have Sanjeev from All India Institute of Medical Sciences. We have Arjun from Teleradiology Solutions from Bangalore. It's a great pleasure on behalf of the Society for Emergency Radiology to welcome all the panelists, and I really thank them for having spared their time in these trying times to share their experiences with us today. So I am sure that this panel discussion is going to be very useful in terms of laying down some specific guidelines in terms of management of the equipment as well as the staff in these situations. And without wasting any further time, I would request Anjali to introduce the first panelist and the question.
Yeah, thank you very much, sir. Our first panelist, Dr. Rafaela is a consultant radiologist at the Department of Neurosciences and Imaging at the University of Katy, Italy. She's also the president-elect of the European Society of Emergency Radiology, and her research interests include various traumatic and non-traumatic emergencies. Rafaela is going to address issues of how to triage your patients now that the lockdown has eased down, but we all know that the rate of infections is going higher in our country, and how to manage radiology equipment, organize radiology space, and how to proceed with sanitization steps and various procedures and protocols. So Rafaela, over to you.
Thank you. Thank you very much, Anjali. Thank you, your colleagues, for your kind invitation. I have to thank a colleague of mine, Dr. Roberta Ciancin, for helping me with this presentation. So this is the area, the region where I live and where I work. My hospital is a university hospital, and we are in Katy, in the center of Italy. You know that the most infected area in Italy were the north of Italy, but also in our region, we have had many infected people. Okay. No. No. Oh, non ce l'ho presa. Okay. Okay, sorry. Okay, here you have the data of WHO updated to 4 days ago. You can see that Italy now is the 4th European country for infected people and the 2nd European country for that after UK. But we have been the first European country overwhelmed by the COVID infection after China. So we had to face like a tsunami in our country at the beginning of the end of February and the beginning of March. And on the basis of the definition made by WHO of suspect, probable, and confirmed COVID-19 cases, we organized our hospital in order to handle patients of different categories And we divided our department into contaminated areas, suspected contaminated areas, transition areas, and clean areas. These are two pictures of our emergency department. And in order to deal with this infection with pandemic, a separate entry to emergency department was created for symptomatic patients presenting with fever or signs and symptoms of respiratory disease. And after triaging these symptomatic patients, this kind of cases, suspected, probable, or confirmed, underwent bedside, and they are undergoing still now, but in less amount respect to, in comparison to the end of February, they undergo to bedside chest X-ray with dedicated portable device in this dedicated emergency unit. And you can see here the PPE equipment our technicians have to wear: a double pair of gloves, gowns, goggles, and every kind of protection equipment. And this is the procedure they have to follow to undress after performing this bedside chest X-ray. If the bedside chest X-ray is positive or was positive for pneumonia, the patient has to be hospitalized. And he is hospitalized with, and it is very important that any accompanying personnel must adopt protection for biological risk. And patients, in every moment, they have to wear a surgical mask during transport. So they are hospitalized to COVID-dedicated wards through designated elevators and paths. Why we use portable radiographic equipment? For example, in our department, we don't use ultrasound to triage patients, but we prefer to use portable radiographic equipment for their sensitivity, and because we have this kind of availability. Because portable radiographic equipment limit the transportation of patients. How can I? Okay. And the dedicated radiographic equipment can decrease the risk for transmission from known infected individuals, and it is very important to use paperless systems in order to minimize the risk of a document-mediated transmission. Which are the steps that the technician should follow when they perform a bedside chest X-ray in emergency room dedicated wards for COVID? First, they have to register and print out the information of the patient and take the list to the clean area in isolation ward. Secondly, they put on the protective equipment before entering the ward. Third, they have to connect the mobile device to the network and store the patient information. Then they have to make an X-ray of the patient's chest. And then, and it is very important to know that the mobile device has to be wrapped with disposable sheets to avoid cross-infection. And after taking the X-ray, these disposable sheets are placed in a special trays being placed. And it is preferable to schedule cohorts of patients of the same time together, for example, with proven COVID-19 infection with positive swab results, to minimize changes in the dressing of operating personnel. This is the same for a CT unit, for example. And the technologists, they have to perform just hand hygiene when moving from one patient to the next. And after the images are sent to the PACS, the technologist can leave the isolation ward. It is very important when possible, I know that sometimes there are limits of personnel, but when possible, it is recommended to use two separate radiographers, one assigned to manage the workstation and the controls, the so-called clean radiographer, and the other assigned to positioning the patients and to explaining the breath-hold during the exam, the so-called dirty radiographer. It is very important that the patients in the emergency dedicated COVID room should wear a surgical mask during the entire examination. But what happens when bedside chest X-ray is negative for pneumonia, but there are highly suggestive positive clinical, laboratory, and epidemiological findings, or if the bedside chest X-ray is doubtful for pneumonia? In our department, we perform high-resolution chest CT in a dedicated radiology unit accessible from designated elevators and paths. And this CT unit is located in a different level from the CT place close to the emergency department. As well as for bedside chest X-ray, any accompanying personnel must adopt protection for biological risk, and patients should wear a surgical mask during a transport. In this dedicated radiology unit, we can find contaminated, potentially contaminated buffer and clean areas. In our department, there is a separate dedicated access between the contaminated area and the COVID-19 emergency unit. The semi-contaminated area includes the CT control room and other patient examination access area. The buffer zone includes access area for medical personnel and a dressing area for technologists. The clean area includes the administrative office and the diagnostic room, and the contaminated area was isolated from other areas using physical barricades built specifically for this pandemic, and directional signs were newly installed to guide patients and staff, as you can see in this picture. Once again, it is suggested to acquire CT examination with the simultaneous use of two radiographers, one assigned to manage the workstation and the controls, and the other assigned to positioning the patient and explaining procedure and the breath hold during the exam. But sometimes, even in our department, due to a limitation of personnel, other support healthcare personnel, such as, for example, nurses, can assist the radiographer appointed to conduct the examination. In our department, radiologists, radiographer, and nurse are present for contrast and CT and for all examination in the emergency setting. Any accompanying personnel must adopt protection for biological risk, and patients should wear a surgical mask throughout the examination. Before each CT examination, the dedicated radiographer or the nurse covers the entire surface of the CT coach with a disposable sheet. And in both the console and the examination room, all non-essential items should be removed. It's very important in order to avoid contaminations. And this is a picture of our console room, which is covered by with waterproof protective material. And if you don't have waterproof protective material, you have to sanitize at the end of the procedure any items which is present in the console room, CT room. What about the routine disinfection procedure of CT unit, or the area where we perform a bedside chest X-ray? First of all, environmental services staff members need to be specifically trained for professional cleaning. It is very important to communicate with our equipment vendors in order to get information about the specific product we have to use in order to avoid damages to our machines. For surface webbing disinfection, we use 1,000 milligrams of chlorine-containing disinfectant and 75% ethanol for non-corrosive surfaces, for example, for CT scanner, including entry and scanner table. And we perform this kind of a disinfection at least twice a day. It is very important to know that disinfectant sprays should be used carefully because they can damage our machines, especially ultrasound machines. What about air disinfection? It is suggested that all central air conditioners are turned off to prevent air contamination with each other. But there is a problem because we know that our CT machines and ultrasound machine needs to be located in a refrigerated place, and sometimes this is very difficult to cope with air conditioner turned off to manage this kind of disinfection. Some colleagues of mine I know in the north of Italy, they bought UV lamps in order to disinfect air, ambient air, and in order to shorten the disinfection between one patient and another patient, but they have a cost, of course. What about the ground disinfection? We use as well 1,000 or 2,000 milligrams of chlorine-containing disinfectant, and once again, at least twice a day. And also we try to disinfect only goggles we use between a patient and another, but all disposable protective products or the other disposable protective products must be non-reusable. The waste of patients with COVID-19 should be regarded as infectious medical waste, of course, and it is strictly prohibited to casually discard masks, gloves, caps, and other protective supplies. So we need to be careful when we dismiss this kind of equipment. And finally, my last slide is about a proposal for patient imaging timeline in a dedicated CT unit. This is what we have done in the past during the peak COVID period, and we are doing the same in the post-peak COVID period. This is a procedure from Spallanzani Hospital, Rome, in Italy. During a CT workstation, we scan 3 groups of patients. At the beginning of the CT workstation, we prefer to scan healed patients with 2 consecutive negative swab results. Usually they are follow-up patients. They are discharged from the hospital, and they are followed in our department after they went home, back home. Or we scan suspected patients with at least 2 consecutive negative swab results. In this case, in this group of patients, no specific precautions for sanitization are needed. After this group of patients, we usually scan a group 2, which is the now they are the most of our patients we see in this moment, in this phase, suspected patients waiting for swab results. Unfortunately, we do not have enough swab results for all patients coming to the emergency department, and also there is a problem for the timing of getting the swab results. So we scan this kind of patients in the CT unit, the dedicated CT unit, but in addition to the routine disinfection procedure we have described previously, air disinfection is conducted for 30 minutes before examining other patients. And finally, at the end of our CT work session, we scan group 3, confirmed patients, and it is preferable to schedule cohort of patients to optimize operation time and to minimize changing in a dressing of operating personnel unless lapsing emergency. We have, for example, some suspected patients from the emergency department, so we have to scan them in the dedicated CT unit. Maybe in the discussion we can debate if it is useful in the post-peak COVID phase have a dedicated CT unit to scan suspected patients. I think in this initial post-peak COVID phase, it is useful to have a dedicated CT unit, especially because now most of our patients are asymptomatic patients, and we do not have enough swab results in order to confirm or exclude their infection. Thank you very much for your attention.
Thanks, Rafaela. Very interesting. Looks like you are using a lot of CT in your hospital. We will come to it later. I'm sure the audience and the panelists will have questions for you. So please wait. And meanwhile, so we have Dr. Ramdas Senasi from the UK, and he will be sharing his thoughts on leadership.
Just give me a second.
Ram, can you see your presentation now?
Yes, I can. Just let me get it back up here again. And whenever you're ready for me to start, I can start.
Yeah, please go ahead and start.
Okay, great, everyone. Thank you very much. Round 2. Well, next slide, please. Yeah, great. No financial disclosure. Firstly, I'd like to thank Anjali for inviting me to join this esteemed group of radiologists and for allowing me to share our experiences, at least in my local trust in the UK. I'd also like to thank the Society of Emergency Radiology of India. And it's also nice to know that India is at the forefront of this battle against COVID and helping to share this knowledge. And also to the World Federation of Emergency Radiology COVID Task Force, which Andrea has mentioned, is a network that we initiated rapidly to help get ahead of the knowledge curve. Next slide, please. And I think this slide here sums up what I would like to talk about today. And I'd like to approach it from a very different angle, and really is who we are and how we act as radiologists when we are faced in times of crisis, where suddenly the lines between the different specialities blur and we suddenly see a change in our roles. Next slide, please. And this is the radiologist's dilemma when we face a crisis like COVID. Our roles suddenly change. We who practice as reporters, as radiologists and managers of a fully functioning department suddenly are thrust into a world where we suddenly are expected to be a leader, change our role to become more of a physician, and suddenly experts in crisis management. Next slide, please. And so these are the discussion points. It'll be a very different angle to what Rafaela did, but I thought these are things to me that are very important, which is issues such as leadership, teamwork, how you manage your team, how do you manage staff who are either suspected or COVID positive, the way we handle workforce and workflow management. I think there's a lot of talk on curve. I like to talk with the knowledge curve. Human factors that we all have to take into account as radiologists, leaders, and doctors. Some of the lessons learned, and how do we prepare for the next crisis. Next slide, please. So I think with regards to leadership, I think crises and any crisis needs effective leadership. People look up to someone, and within a radiology department, that usually falls on the radiologist. Doctors are always seen as leaders in the community, and this is the same in a hospital. We have to shift our mindset. And this is in some ways, and how people may have described, this is all-out war in an unseen, with an unseen enemy. And if we see how all the other countries have reacted, we have moved from peacetime to wartime, and we have to have that mindset. I think the Royal College of Radiology and NHS England have advised that each department should have a dedicated lead, and it should not be the head of department. The head of department should delegate that duty to one specific person to take on this battle, to manage the group, manage the education, manage information flow. And I think as an effective leader, two very important things that I found very useful is firstly, bringing the experts within the department. When we have time to prepare, and with all the knowledge and expertise coming from countries such as Spain and Italy, and Rafaela will remember the conversations we had at night, exchanging ideas, I decided to speak to the experts in my department, who are the CT technicians, the ultrasound technicians, try to learn what they knew, how we can try and manage the department in the most effective way. And this is an important thing, flattening the hierarchy. This does not mean it's not the leader. It means that you're listening to everyone, understanding. And I think this is a listening game. It's all about learning and how do we go forward. And I think to be an effective leader in a situation like this, you need two-way communication. You need to talk to the members of your team, listen to the fears, listen to the ideas. And as a leader, we synthesize that information into something that's cohesive, effective, and can be deployed rapidly. Next slide, please. And this takes you to teamwork when I talk about how listening is important. At the same time, use your experts to bring in the best evidence within their areas of expertise. For our radiographers and technicians, it's the Society of Radiographers. Within radiology, we bring in expertise. We take this best evidence, we evaluate it, but then we need to speak to our managers about local policies and how we can implement these new changes into existing policies. And this will be unique from country to country, organization to organization. But it's always important to make sure that whatever you implement does not conflict with existing policies in your hospital, although we all want to make a difference. And these are 4 E's that I always use with any interaction with my registrars, with my colleagues, with other team members. Engage with your team. Encourage them to do the best they can. Empower them that whatever they do, we will achieve it together, and enable them. Do whatever it takes as a leader to allow them to accomplish their mission goal. And make those telephone calls, send out those emails, make their life easy. When you do that, you will have an effective team that can respond rapidly to any changing situation. Next slide. Managing the team also brings us the issues of workforce management while trying to maintain some regular department commitments. And this are the 4 R's. You have to review the skills within the existing workforce. This not only means the radiologists, but the radiographers, your advanced practitioners, your cleaners, your healthcare assistants, who can do what. You may need to reposition people. We talked about radiologists working from home. That's very easy, but you also need some presence in the department for effective leadership. So that comes to rota management, speaking to your colleagues, identifying who can be in, who can be out. Some places do a 50-50 swap. And then reallocating time. We have to move from a normal 9-to-5 job to some of us work from 9 to 2, some work from 2 to 7, others work from 7 to 12. It is changing times, we move with it. And of course, in the UK, there is the issue of redeployment, where if the radiology department was quiet, we've seen radiologists being redeployed to the ITU department or to the emergency department. So you have to then prepare for what will happen if you're a radiologist in a quiet department and redeployed to a different department. Whatever you do, it has to be sustainable and it has to be achievable so you don't achieve burnout within your staff. And I think as radiology leaders, we have to deal with management. Management at the upper level has to have a strong radiology presence because our role is to educate them on what radiology can do, what radiology can't do, and what we need from them to make our job effective. And constantly stay ahead to pass policies through. If they don't listen, if we don't talk, we will not get our agenda through. Next slide, please. And so what do we do with suspected COVID and symptomatic staff? Now, I would like to remind everyone that cultures, practices differ from country to country. There is no right or wrong, and that is one of the things that I learned. You cannot criticize what another country is doing. Everything is done to reflect the culture of the people, the existing healthcare policies. Within the UK, at least in my hospital and most hospitals, all the staff have a dedicated staff advice line specific for COVID. They can call if they have concerns. They can call if they have any symptoms. They can even call if they need mental health support, which is a very important issue to consider. Staff that fulfill the criteria for COVID symptoms or suspected COVID disease would be offered testing. I myself was COVID positive, although I had a mild form of the disease. My hospital arranged a test within 4 hours of me calling them, and I had a result within 24 hours, which was to me remarkable for the Northeastern Hospital. We were advised to stay at home for 1 week and only return when symptoms are free. This may differ from country to country. Some would require 14 days of quarantine. And of course, we also identified staff at risk, looking at age, underlying health factors, and now a latest study by the UK looking into COVID affecting the Black, Asian, and minority ethnic communities found that we too were at higher risk. So we all had to do a risk assessment to see if we were at higher risk within our workforce exposed to COVID. Those of us who do fit this criteria would be offered home working when possible. Some hospitals have paid accommodation for isolation and also reach out to the public and private sector. A lot of hospitals within our region were offering free accommodation to healthcare staff to allow them to be isolated from the family members who themselves might be high risk. Next slide, please. Workforce and workflow management. I think the key thing to remember is this is an ever-changing situation. It's like a football match or a cricket match if you're in India. You have to constantly study the situation. You should also have a business continuity plan if you have only 75 workforce capacity. In some places, it might come down to 50%, and we see that happening in other countries. You need, as a leader, to identify priority areas within your department, cancel non-priority work if necessary, engage your radiologists and clinicians to discuss who needs it, who don't, and plan for have contingency plan for key areas. As a pediatric radiologist, my area was child abuse imaging. We knew that there would be an increase in child abuse because of children being isolated at home with their parents, especially those the lower socioeconomic groups. So we made sure what would happen if none of us were here. How do we deal with these issues? How do we protect the children if not all the key members of the staff are here to do this specialist work? And so preparation is key if you have time. For example, Italy was sending us information, and we used that information as gold dust to prepare ourselves and get everyone involved. Next slide, please. Everyone is talking about flattening the curve and the COVID curve, but for me, I think the key thing as clinicians, as doctors, is the knowledge curve. Knowledge is king, and I think the formation of the World Federation of Emergency Radiology, as Dr. Agarwal had mentioned, was key in all of us being prepared, at least for me. We have to stay ahead of the ever-changing knowledge base that is coming out on a daily and weekly basis to maintain optimal readiness. And as I said with the World Federation, develop networks. WhatsApp is an excellent tool. Connect with everyone, learn as much as you can, and prepare, exchange notes. And we found it very useful in our WhatsApp group. And it is a real-time issue. Review and constant reassessment of the situation. This is war, as I said before. We have to change our approach and get ready to sidestep. You may be doing something, new information comes in, reevaluate, reassess, review, change. Next slide, please. At the end of the day, we are radiologists, but we're also doctors, and that is how we've always been trained, and we always have to consider human factors. You will deal with staff who are fearful of the changing situation. Some of them will be fearful for themselves. Some of them may be fearful for their family members. Media sometimes does not help. It can elevate anxiety. And when you have staff members with elevated anxiety, you do not have an effective team to work with. And sometimes lack of clarity and understanding leads to this. So as the COVID lead for my department, my 3 C's that I used when I walked around maintaining social distancing was to connect with my staff, clarify with them the information I had and what I knew, and as a doctor, comfort them. And I found this to be very effective. And that in itself gave the staff confidence to come to work and to work to their best abilities. Next slide, please. I think there are lessons learned from this. I think as doctors, we have to learn where we did well, what we did well, where we went wrong, and what we can do to be better in the future. I think listening is the name of the game. Knowledge is key in management of crises and alleviating fears. Sorry, I do apologize, alleviating, not elevating. And you have to create pathways to prevent bottlenecks in the process. So you need to connect and communicate with management, make sure all your policies are passed through quickly so you can have an effective team ready to deal with the problem. Leadership and delegating roles to maximize the available skills within your group. Use your registrars, use your trainees, your residents, your other staff, and adaptability to an ever-changing scenario, which I think a lot of us did. Next slide. Basically, this will not be a typical working day, week, or month. Next slide. Going forward, I think every organization and department should have an established crisis team so that if there is a crisis, you've already identified people who can come together with identified roles so that we can stay ahead of the game. I think at the end of this, as we are doing now, I think we need to debrief and have a proper and have process analysis. Where can we make the changes so that things are much quicker and more efficient in the future? Rapid decision-making is key. You need to reduce the amount of bureaucracy within your organization. I think the human touch as doctors is very, very essential. We should not deviate from our oath as doctors. Although we're all radiologists, we're still doctors at heart. And as a young Boy Scout, I think those lessons learned from my teachers when I was 10, 11 years old, be prepared. It's such a simple motto, but it's a motto that will help all of us now and in the future. Next slide. So that is the end of my slide. Thank you very much.
Thank you very much for outlining the basic principles of how to run a department and what are the essential skills that one needs to have as a leader and kind of just, discussing the basic framework. I would next move on to our expert panelist, that's Dr. Anju Garg. She's head of the department at Maulana Azad Medical College and affiliated LNJP Hospital. And she's at the helm of a busy COVID hospital. And I want her to share her experiences on how to stay functional in the midst of all this COVID panic and anxiety. Dr. Anju, over to you.
Yeah, hi. Good afternoon, everyone, and thanks, Anjali and Dr. Sanjeev Sharma for inviting me for this discussion on how to prepare, what to prepare, and how to manage. So, Lok Naik Hospital is one of the largest, or should I say the largest, designated COVID-only hospital that we have here. It is offering a capacity of 2,000 beds for COVID-only patients. And in the next few minutes, I'm going to try and tell you how we are managing it currently. And so for the last 2 months, that is since mid-March till now, mid-May, our hospital has gone through a lot of phases. Initially, we began with, of course, a few patients of COVID coming in. Most of our patients were non-COVID, regular patients, routine OPD, routine emergencies, and routine inpatients. Slowly, as we moved on into March, there were more and more of COVID patients. And then, so there we had one floor dedicated to them, then we had 2 floors dedicated to them, then we had a block dedicated, and then eventually in early April, our hospital was declared as a COVID-only hospital. So we had COVID suspects and COVID positives. All other patients, inpatients were transferred out. OPDs by that time had already stopped functioning. By mid-April, amongst the patients in the hospital, even the suspects were now transferred out to COVID centers, and we had only COVID positive patients, no suspects. And currently, the situation is that Lok Naik is a tertiary care hospital, and it houses only those COVID positive patients who are moderately to severely sick. That means the mild or the asymptomatic COVID positive patients have been sent on home isolation or transferred to COVID care centers or health centers, which have been set up by the government. So this is just a slide to show you how we fared, how the radiology department fared from February to April. So the red is February, yellow March, and the white ones are the tests done in April. So you can see the radiographs that we had numbered in 27,000 roughly in February came down to almost 250. And so the ultrasound scans from 5,000 to 40, the CT scans 3,700, 66, and MRI from about 900 to just about 30 odd MRs in April. This was when we still had some regular patients, indoor patients, before they were all discharged in April. Now, to adjust to both these things, that means the different type of patients now coming in, only COVID positive patients, and to the fact that we were going to have very different kind of imaging being done, we had to restructure the imaging services in our hospital. This is just to show you a very line diagram or a block diagram, I should say, for the how of all of our hospital and what it looks like. It is situated along a 0.5 kilometer stretch along a very busy arterial road, and there are these various blocks which all have an opening or can be accessed from this road. So we had all these red blocks are where the patients are admitted and housed. So we had the medical patients, pediatric patients, gynae patients, surgical patients, which are increasing day by day, and more surgical conditions in COVID positive patients are being referred to our hospital. And then the ICUs. The ortho block currently is vacant, and there are a few more blocks which I haven't put here, which are currently vacant, still to be filled. Currently, our hospital has about 600 COVID positive patients lodged in these various blocks. So now, how do we manage to do the various investigations that we do. So we have placed mobile X-ray equipment in all the major blocks so that we don't have to shift them around, because it is difficult to move from one block to the other as they are a little distance apart. Along with that, we've tried to, and these are conventional X-ray equipment. Mind you, we do not have digital mobile X-ray equipment. So we have tried to get some tabletop CR systems, which we have put in those blocks in which more X-rays are being done. And we are trying to get them networked into the main department or emergency section, as our hospital did not have a functioning PACT system. So, yeah. So here we have put all these portable X-ray machines. In the emergency, we have a luxury of 2 areas with almost a full setup of radiology. One is in the emergency section, where we have a CT and we have an ultrasound and we have a DR system. And so this area we have made as a red zone, where anybody requiring these investigations is brought. Whereas the main radiology department is the green or clean zone, from where we operate. The rest of the staff sits here and does the rest of the departmental activities, and coordination occurs from this main department. So remember, all our hospital is a COVID-only hospital. All our patients are COVID positive. So there is no uncertainty on the protocol to adopt while we conduct any imaging. You have to take full precautions, right? And the issue of patient safety doesn't come in too much, because all the patients are COVID positive. It's only staff safety which we are concerned about. Another dictum that we have followed here is that the imaging will only be done for those patients where it will impact the management and not otherwise. So while following this impact, the most common imaging investigation that we are doing are the chest radiographs. The chest, and these are only about 15 to 20 chest X-rays per day. This is the sum of the X-rays that we are doing. They are not universally done in all patients, but only those with specific indications to rule out an underlying disease, to rule out to see the burden of lung pulmonary involvement in the COVID patients, and sometimes to follow up these patients to see how they are progressing. Very few other radiographs are being done for other non-COVID indications. Amongst the CT now, we are not doing CT for diagnosing. We don't need to. We already have our RT-PCR test done, proven positive patients. So we don't need to do it to diagnose at all. The one indication that we are doing chest CTs for, if there is a worsening of symptoms and the clinicians think that there is an alternative diagnosis for this worsening and not COVID, then we will do a CT chest. But if it is thought to be due to COVID, the CT will not really add to the management. And other CTs are being done for non-COVID indications, as we are getting patients with other diseases who are COVID positive, right? So we do roughly 1 or 2 CTs per day, on the whole, not more than that. Then the ultrasound, we are doing mainly fetal or antenatal ultrasounds, as patients in the last trimester of pregnancy are being admitted for delivery and cesarean sections. And we are doing ultrasounds for surgical indications, but we are not doing bedside lung ultrasounds to follow the progress or to look at the progress of COVID changes in the lungs. The famous POCUS technique, we are not using that in our departments. So we do around 3 to 4 or 5 ultrasounds in a day for these indications. Till now, we have not been asked for an MRI in a COVID positive patient, so we haven't yet done any MRIs for these patients. Now, how do we go about planning these investigations? The requisitions can be sent for ultrasound or CT to the emergency section or the main department, either digitally or written form, as it is convenient for the clinical department. The indication is verified, and then the examinations are scheduled such so that we can club them together and keep them in a defined span of time to conserve the PPE for the staff. The patients are transferred from the ward to the emergency section in an ambulance, because these places are not very close, and we cannot have patients walking in or coming on a wheelchair or trolley. So ambulance is arranged, and as you know, there is a road which connects almost each block. So they are transferred via ambulance, and they definitely wear a mask. Other PPE beyond a mask, like a cap or a gown, is optional. Some patients do get them and come with them. When I'm in the emergency department, then of course the radiologist, the radiographer who's doing the scan, positioning the patient, along with, as discussed before, the second person helping him, they wear proper PPE and conduct the scan. After the scan is over, patient is sent back, and then the equipment is sanitized and the room is cleaned at the end of the session, as has already been discussed in the previous talk. So how have we tried to deploy our staff? Now, we have tried to minimize the number of staff coming in every day to restrict to only a certain number who are required. As you saw, there was a marked drop in our regular investigations. In fact, regular none, only these. And so there is very few investigations being done in the department on a routine basis. So we have divided our staff into 3 groups, and we come in, one group comes in at one time to conserve the manpower, to protect against infection, and also to reduce crowding in the department. We have made teams of the people who are going on to emergency duties, and block duties have been assigned. Like you do go in, one team does duty for 1 week amongst themselves, and then a buddy system has also been adopted. That is, instead of putting a staff or a radiographer or a resident on for 6 hours at a time, we put them on, 2 of them on for 12 hours. So 2 people are there together, and it increases their comfort level to be working there. Besides the radiology services, some residents have been posted from our department into the wards for patient care, and some residents have also been deployed into the field at district level for miscellaneous duties like contact tracing or even running OPDs, regular OPDs. So we have lost some residents there, and our staff has been depleted. Then other miscellaneous staff, again, rosters have been made on a need basis. So many other general measures that we have taken, in which SOPs have been created for working protocols of the department. And as mentioned before, these are changed so frequently that it is sometimes difficult to adjust to this. Every morning we look at, okay, now what's the policy today? What was the new thing which came out? What has changed? And accordingly, we have to change either the SOPs or the rosters. It's a difficult situation. Extensively, we use online communication, the telephone, WhatsApp, email, and we are getting used to this, meeting platforms. Even IT challenged people like me, now we are getting used to these platforms on a daily basis. Senior staff is always available at all times to listen to the problems, either personally or on the phone, and to find solutions for the problems. The training and education for all the staff regarding the self-protection, hand hygiene, PPE, donning, doffing, etc. is available and is conducted on a daily basis by the Infection Control Committee. So people have attended these and gained some knowledge, and maybe it has helped them to overcome their fears. We've also tried to make sure that there is adequate and appropriate PPE, and it is available to the staff, because initially they had a real problem, because we also had a problem because there was a lack of PPE, even masks were not available. But however, now in this time we managed to get enough PPE, and there's no problem in the PPE, and also the quality is in better control now. So hydroxychloroquine has been provided by the hospital to all the staff, to whoever wants to take it as prophylaxis. And again, so we are ready, and the hospital is ready to provide quarantine or isolation facilities, paid accommodation, and sampling at any time and there is any question of exposure or contact to a COVID positive patient. And besides all this, if still people are apprehensive, there are meditation classes and counseling which have been offered. So currently, the early lockdown which gave us time for preparation, for creating department-specific SOPs, for reorganizing our workflow. We have not been overburdened or totally flooded with patients. Education and training of staff, as I said, has also made a difference. Stress levels were very, very high in the early period at all levels of staff. They have reduced, and as people have adapted and are learning to adapt, I will not say they've gone away, they cannot, but yes, they have reduced. It is an ongoing process is ongoing to ensure the health of our workforce and to plan for further increase and sufficient staffing in that time. We do not know what will happen tomorrow, and we need to deal with it as it comes. Thank you.
Dr. Anju, thank you very much. I think this webinar and panel is dedicated to all your staff and the staff that's working globally in various COVID and mixed hospitals. I think the cleaning staff has a huge role to play. We'll discuss more. Hopefully, we'll have time to discuss during our panel discussion. I move on to the next panelist. We have Dr. Sanjeev Kumar. He's from All India Institute of Medical Sciences, New Delhi, and is an associate professor in the Department of Cardiovascular and Interventional Radiology. He will be sharing how he is implementing these safety protocols in interventional radiology. Sanjeev, over to you now.
Thank you, ma'am, for inviting me, and thank you, sir, for giving me the chance to speak in this platform. So I hope my screen is visible to everyone.
Yes, we can see it. You just have to put it in the slideshow format.
So, okay, so ready to go. So I'll be talking about the protocols to ensure safety in the intervention radiology procedures, and which actually starts from the overall hospital safety protocol, but there are certain points which is specific to the intervention radiology procedures, which I will try to highlight in this 5-minute presentation. So this is just the glimpse of the procedures we have done in this period. You can see the case 1 is actually a contained rupture of type B aortic dissection, which has been salvaged by endovascular stent graft placement. At the case 2, you can see that this patient is of lymphoma. Patient was planned from chemotherapy, and then there was an inadvertent PICC line migration into RA, RV, and PA, and the patient presented to us with arrhythmia. It was very severe and symptomatic arrhythmia, and we taken the patient for the foreign body removal. The third case you can see is patient who was operated for frontal meningioma and developed DVT and P in the acute post-op period, and patient was referred to us for IV septal replacement, which was done in this case. And if you look at the fourth case, this patient presented with a massive hemoptysis, which was referred to us for bronchial artery embolization, which was done successfully in this case. So the point to discuss is that to formulate an optimal safety protocol in an intervention radiology procedures, it's important to know 2 very important principles. The first principle is to know the kind of the intervention radiology procedure you are planning, which in terms of emergent or urgent nature. For example, you can look at the left-hand corner that this is a case of a ruptured abdominal aortic aneurysm with a hemodynamic instability. So this kind of patient cannot wait for knowing the COVID status of the patient, and you have to intervene immediately. As opposed to this next patient, where the patient presented with a pain abdomen, and on imaging you see a liver abscess, you can probably wait for a certain period of time to know the COVID status, and then you can intervene successfully after a certain period. Secondly, what is more important to know is that whether a given procedure is an aerosol generating procedure or a non-aerosol generating procedure. For example, a bronchial artery embolization. This is a aerosol generating procedure which requires different type of PPE or protection versus a procedure like a percutaneous pictal drainage of a liver abscess, which is a non-aerosol generating procedure which requires a different grade or different class of PPE. Thirdly, when you decide that you need to intervene, you need to know what kind of image guidance you are going to get for doing the procedure. So if you can do with a portable ultrasound in a ward or a bedside, that is sufficient, or maybe with a portable C-arm. But if you require to shift the patient to a high angiographic suite, you need to your approach will be totally different. Similarly, when a patient presents in the emergency, you have to be sure about the COVID status of the patient. whether the patient is definitely positive, or maybe based on the symptom, the COVID is possibility is very likely. In no symptom patient of COVID, you can suggest that okay, this patient is COVID unlikely, and then there are cases where there is a documented COVID negative patient. So the management and the safety protocol in intervention radiology suite will heavily depend upon these two factors, that is the type of the IR procedure and the COVID status of the patient. This is a slide which summarizes or which shows the pillar of the protocols to ensure safety, which is applicable actually to overall hospital procedures, and certain points are very pertinent when we talk about the intervention radiology procedures, which I will discuss one by one, which starts from the patient segregation, which has already been discussed by various speakers. Then the second step will be staff segregation, which has also been discussed. Waiting and prioritizing of the procedure is very important, minimal movement, enhanced workflow, and strict infection control. And I will come to each one by one. So patient segregation has largely been discussed by all these speakers, and we know that this is one of the most important strategy, whether we are doing imaging or intervention, to prevent the cross transmission, and more importantly, to ensure adequate safety measures according to the risk to the patient. So what we have done in our hospital is that we have divided the hospital in two parts. One is the trauma center, which has been totally devoted to the COVID positive patient, and any patient who is COVID positive will be shifted there. A patient who is COVID likely based on the symptom and results are RT-PCR are waiting, the patient is shifted to the isolation ward in our main hospital, and then the COVID unlikely or negative patient, they will be sent into the general ward, and they will be treated in the routine way. Moving on to the staff segregation, it has also been discussed, and we know that it is also an important measure to prevent infection control. That is, dividing the staff either based on the temporal principle or physical distancing is very important. It not only ensure your adequate safety control, but also provide with your adequate staff unless until someone falls sick. Prioritizing of procedure, I want to highlight, this is very, very important. Like I will give you an example of a patient. A few days back, we had a patient which was referred to the emergency department with an isolated infrarenal type B aortic dissection, presented with pain, and referred from some hospital for urgent intervention. The patient and the patient attendants all were very afraid. When we see the patient, we look at its hemodynamic status, we look at the imaging morphology, and we find that the patient hemodynamic and the image morphology is suggestive that the patient can put on safely on a conservative treatment and can be asked to come on follow-up, and then probably a decision to intervene can be taken. So this is very important to prioritize what you want to do, and this should be ideally done by someone who is senior or had enough experience in the department. But once you have decided that you have to intervene in a given patient, this principle, that is the minimal movement of the patient, should be followed, whether it is a COVID negative patient or definitely it is applicable to patients who are at suspected risk or patients who are actually positive. So if we decided that minimal movement, that means that if we can do a intervention radiology procedure by the bedside by using a portable ultrasound or maybe a mobile CM fluoroscopy, it's better to do at the bedside. But if you think that the procedure requires a high angiographic suite, like doing a endovascular aortic repair kind of procedure, then the patient needs to shift it to a high-end cath lab. And then the role of enhanced workflow came into the picture. What it means is that enhanced workflow, that once the patient gets admitted to the ward, movement to the cath lab, IR procedure, then again getting back to the ward, it requires a coordinated and a smooth coordination between various staff, your own staff, staff from the anesthesia department, the security personnel, the environmental services, the infection prevention, the liftman, so on and so forth. So a coordinated effort is very much important if you are moving the patient. What is more important to remember that you should have a checklist before transferring the patient to the IR lab, specifically in the terms of the COVID status of the patient. Patients who are being transferred to the IR labs must wear surgical masks, and all the professionals who are posted in the IR lab should wear the surgical scrubs and masks throughout the work shift. So when we decide of enhanced workflow, infrastructure modification is also an integral part of this. And the blueprint of your cath lab and the path of transfer from where, which lift you are using, how you are making the patient to enter into the cath lab, and what is the exit plan, all should be clearly documented and rehearsed. In our center, we have 5 cath lab, and one of these cath lab has actually been devoted to the COVID suspect, which is essentially treated in the same way as a COVID positive patient. And how this COVID suspect or this quarantine IR lab is different from the routine lab is that you only kept only the fundamental materials in your quarantine lab. You try to stop the laminar airflow when you are doing the procedure, because this makes the staff prone for infections. All your accessories should be plastic wrapped, and the door should ideally be closed all the time. I mean, it should not be opened up only while entering of the patient or the staff. And forget about the Mary of having plenty of IR in the same suit. You should allow only professionals who are absolutely necessary for the procedure, and no extra healthcare workers should be inside the quarantine IR lab. Moving on to the infection control, which is the integral part, and it starts much before the onset of the pandemic because it entails education and training of the medical and, more importantly, non-medical staff. If you remember your cold chain of vaccine, and if the cold chain breaks at any point of the time, the whole vaccine gets ineffective. Similar is the way that if your infection control program get vanished at or get looped out at any of the level, your whole effort will get out. So this is very important. Education, training, rehearsing each and every staff, whether it is a sanitary worker, whether it is a security guard, whether it is a liftman, all this should be followed. Knowledge of the personal protective equipment, the types of equipment, and the indication for different kind of IR procedures should be thoroughly known to the intervention. I would like again to highlight this donning and doffing of the PPE, and if done in an adequate manner, the chances of transmission is actually very negligible. So these are some of the important pertinent points when you are dealing with the patient in the intervention radiology suit, that you need to have a high standard of infection protocol, which is mandated by your institute. All the medical waste after the procedure should be delivered into your biohazard waste disposal bag. This is important. You should not leave the IR suit with any of the protective equipments which you have used during the procedure, except for the respirator, and you remove the respirator outside the lab. A strict discontamination measure in the IR lab after the procedure, that is the terminal disinfection of the labor, is very important after each and every procedure, and the ideal gap time between the two procedures should be 2 hours. As I already highlighted, the path used to transfer patients should also be sterilized and clean, and often at times you use this thyroid seals and protective apron in the lab, so all this should be routinely cleaned with an adequate disinfectant. And finally, education for patient and their visitor is also a very important control measure to ensure safety to everyone, including the attendant as well as the staff. So I would say that it is very important to remember that it is a very ever-changing dynamics. If you remember, at the onset of the pandemic, we were saying that, okay, this mask business is nothing to do and it is not advised for the general population. But now if you see today, we have mandated it by law that everyone should wear mask when he is getting out of the home. So we should remember that this change is the new normal, and getting used to this is very important, both physically as well as the mentally. New workflow should be established, it should be documented, rehearsed, reviewed, and improved each and every day, because there is a lot of knowledge which is coming each and every day. And remember, this is very important. Again, I am saying that everyone play a key role. You are either a sanitation worker, your liftman, your security guards. So adequate training and coordination and effective implementation is only possible when all these stakeholders coordinate with each other very carefully. So to summarize, I will say that a patient who present in the emergency, if he is a COVID positive, we shift him to COVID hospital and treated accordingly. A COVID likely patient is actually challenge where if the indication is emergent, where we cannot lose the time, the patient is shifted in isolation, and treated in the quarantine IR lab, or if possible, they should be treated on the bedside. A urgent procedure, we can keep the patient in the isolation, wait for the RT-PCR result, and based on the result, we can plan the intervention accordingly, whether in the quarantine lab or whether in the general lab. COVID negative patient shifted to general ward and treated as a regular intervention radiology lab. The debate is actually the patient who had no symptom, whether we should screen them for with the RT-PCR or not, because this group of the patient, which is creating problem for the healthcare workers, because we take the patient because don't have any symptom, and later on they turn to be positive, and by the time we know this, many of them get infected or get quarantined. So this is the group of the patient which is actually very, I would say, dangerous for a healthcare worker and as a overall to all the population. Thank you very much.
Thank you, Dr. Sanjeev. That was an excellent overview of how to handle interventions in the current scenario, and you covered all possibilities. I guess it's best for us as healthcare workers to just stay safe and take all the precautions, because we have so many asymptomatic carriers, as you discussed. I will just request all the participants to please start posting your questions so that we can take them at the end of the session. And I will move on to now Dr. Arjun Kalyanpur, who is the Chief Radiologist of Teleradiology Solutions and my colleague. You know, he has seen the pandemic up close, but from a distance, being in a teleradiology setup. And I feel, being a teleradiologist myself, that it does appear to be the silver lining to this dark COVID cloud, in a certain sense, I guess. And, you know, while some of our radiology colleagues had to temporarily shut shop, work for us in teleradiology was as usual. But I must say that remote workflow can be disjointed, and it really needs novel solutions to keep the team together. So I would let Dr. Arjun discuss as to how he managed to keep the ship afloat. Arjun, over to you.
Thank you very much, Anjali. I've got a small PowerPoint, so I'm just going to share my screen. And can everybody see my screen now?
Yes.
Yeah.
Yes.
So thank you. This is a brief presentation on teleradiology in the time of COVID. And as Anjali said, I'm going to focus on the changes we've made. But just as a background, you know, as we know, teleradiology really can play a big role in a pandemic situation. One is because it provides international support, and therefore, in a global pandemic in particular, it can have extreme use across international borders. It functions as a backup for in-hospital radiologists in spike and emergency situations. And because it's been around for 20 years, all the protocols and workflows are established and set. So it is in good state to be able to cope with the needs of a pandemic. But fundamentally, what we see with teleradiology is that it's benefiting radiologists. So it allows us as radiologists to remain productive while keeping us isolated from the rest of the community, which in turn protects us radiologists from infection risks and facilitates social distancing for the community as well. So there are multiple benefits of teleradiology in the setting of a global pandemic such as we are currently in. In terms of its impact, currently we are seeing, so as Anjali said, teleradiology is kind of a mirror to radiology. We're a reflection of all of your departments, and as a result, we are also seeing a drop in our teleradiology volumes overall related to a hold on non-emergency imaging across the world. But there's a corresponding increase in COVID-related imaging. In the future, we expect that things will bounce back. There will be an increase in emergencies and ICU admissions overall across the board. And then there is also the constant risk of potential quarantine of radiology staff. So teleradiology is an inbuilt mechanism for ensuring that the resources are protected and the capacity is maintained. Now, as far as our response as a teleradiology organization goes, and to address Anjali's question as to how we've kept the ship afloat, I think the primary thing has been a rapid response to change. And as Dr. Ram alluded to in his talk earlier, this is key to the ability to adapt very quickly. I think is very important in a pandemic scenario such as we see. being able to adjust schedules and workflow in response to situations such as lockdown, where volumes one day can be very low, one day can be very high. That ability to adjust and adapt is very important. Protecting our healthcare staff. And the interesting thing is, even in a teleradiology organization where people are working from home or remotely, you can do a lot, even though it doesn't necessarily involve providing PPE. We've been doing virtual physiotherapy sessions for our staff, telecounseling sessions for people who need it. So there are a lot of things that can be done online to protect one's staff as well when you're globally dispersed. We've been using technology. Primarily, the work we do is technology enabled, but in addition to have virtual parties and virtual connects of all our radiologists. This picture here is of an interaction I'm currently having with all of our radiologists everywhere in the world. This is Dr. Olszewski, who's based in Chicago, and we're having a call with him with our head of operations and head of HR. There's been a strong focus on training at this time, specifically related to COVID imaging, of course, as in the form of this current webinar, but also of testing of and upgrading capabilities, as well as updating all our documentation and SOPs. And finally, and not inconsequentially, is at a time like this when the world is also struggling economically, I think it's a good time to review and eliminate non-essential expenses. So that is also part of our focus area. In terms of online communication and collaboration, teleradiology offers a very unique way for people to stay connected wherever they are in the world. Here on the right side of the slide is an image, is a world map showing the distribution of our radiologists. You can see there's a cluster of us. Well, cluster is probably not a good term right now, but a group of us based in India, and another group that's based in the US, and then some of us are in Europe and the Middle East. So this is a meeting that we had. It was kind of an office party where we all connected, and we even did a radiologic dumb charade, which was a lot of fun. So it's great for team bonding, and of course, from the teleradiology workflow perspective, over the imaging cloud, one can remain connected, take second opinions, and discuss complex cases. In future, I think there are going to be challenges. We probably have a separate discussion on this, but fundamentally, I think the gist of what I would like to convey is that teleradiology is uniquely positioned to help in the environment of a global pandemic, and the ability to very rapidly make course corrections at this time is key to allowing it to afford maximum benefit. Thank you. Back to you, Anjali.
Thanks, Arjun. Yeah, teleradiology, I think it is going to have a much wider adoption. I would just like to open the forum for discussion. I would request the participants to please post your questions. Meanwhile, Dr. Sanjeev Sharma has, we can just have, do you have any questions? Please feel free to ask the panelists. And, I was just wondering now that we have, the lockdown has been eased down, but, the COVID infections are rising, and we are going to see a very mixed population in our hospitals. How are we going to deal with the new challenges that the whole situation poses, and what are the possible solutions? Maybe Dr. Anju, would you like to address that, what challenges do you think you are going to face as the head of the department, and what are the possible solutions?
So what I just heard today is that yesterday's toll was 600 plus in Delhi. So if you look at the graph, it is a daily increasing number of patients for us in Delhi, yes. And of course, we are getting only the COVID only, and only the moderately, severely sick patients. We have to keep conserving our resources. We have to make sure that our staff remains healthy and we don't have people going into quarantine too much. Not only healthy physically, but healthy mentally. So that this thing carries on. It's not going to go away. It's just not going away.
I just hope that the COVID, acts as a catalyst for the hospital administration and your department to adopt facts and go digital. That must have been a
Yes,
huge
we have
challenge
started
for
in
you.
a small way. Yes, we have started, as I was telling you, our triage systems we have installed in the blocks, and we are getting them networked to the main department. So we are starting small. Let's hope this thing goes ahead. But again, budgeting, government budgeting at this time is all for COVID, and necessary COVID. So I don't know, that's a big jump required. So let's hope we can try.
Might I add something? Oh, sorry.
Yes, Ram, please do, please.
I agree, Dr. Garg. I think my opinion is, my feeling is, with every defining, like previous defining moments in our history, this is one of our defining moments. And like previously, it always allows a technological leap in the way we do things. And this defining moment has forced us to reevaluate how we work, how we communicate, how we even interact with our patients. So if there is a silver lining into the cloud, I feel that this technological leap will allow healthcare to reach those in need a lot easier than ever before, especially with now the rapid development of telemedicine. And now we can see how this can make a major change to a wider population in the world. I hope everyone probably sees the same view as I do.
Yes, Ram, thank you. I totally agree with you. I think this COVID pandemic is going to usher in digital health in our country in a big way. It wasn't in vogue. I mean, we've been talking about it. We've been doing it in smaller groups for a very, very long time, just not widely accepted by physicians or by patients. But I think it has to come from the physicians first. So yeah, I think it's going to be a major change. I just wonder, Sanjeev, thanks for your presentation. And, I've been to the department many times, and I wonder how, it must have been challenging as far as educating your patients goes. Have you put in all signs in all the corridors? How the patient traffic is going to flow, and how are you training the sanitization staff? Are you holding sessions for them in the department, or do you have a centralized team at AIIMS that is doing so?
So there is actually a dedicated team of the infection control, which is doing regular sessions day and morning and night and all the times, teaching all these staff about the adequate precautions which need to be taken for the infection control. So there's a dedicated team of doctors, residents, nurses, staff, which is there, who is teaching all the staff, whether medical or non-medical, because everyone needs to know. I mean, if you look at a simple example of wearing a mask, you will find that 50% of us are not wearing the mask properly. So they are looking at the minute details. They are looking at the minute details, which are very, very efficacious in preventing the transmission. If you look at these signboards, yes, because in this lockdown, actually the regular OPDs have been closed. And now we are, but as you said, that digitalization is the way to go. We were doing academic classes for 2 or 3 hours on different platforms, online platforms. Also, this consultation based on the telecommunication or the videos has been continuously been going on the AIIMS, giving.
Sanjeev, could you unmute yourself? We just lost you. Could you unmute yourself? Just unmute. Yeah, okay. Thank you.
So I was just saying, in this lockdown, the OPD was actually closed, so we had the emergency patient only. But at the same time, we had this Teleradiology team, which was doing consultation based on different departments to the patient who had already online appointments. And now, since we are planning to open up, now, as you said, that we had all these signboards giving instruction to the patient. Earlier, you see that with one patient, there will be 4 attendants. Now, all these things are making very mandatory that with one patient, only 1 attendant. Now I don't know how we are going to tackle, because COVID, if you look at COVID as a cause of mortality, it's still far less than the other diseases we state.
Right,
so we need to have a balance. I don't know what's the message to be given to everyone. We cannot say that forget it, let's acquire a herd immunity and then fine. But it's a very difficult question actually, how to balance between a COVID versus a non-COVID patient.
Yeah, that's it's difficult indeed. Yes, Dr. Anju, please.
So another major point of concern, which I actually wanted to address here, is the training of our students. You know, our hospital has a very large college attached to it, 250 undergraduate students coming in every year, and more than 150 postgraduate students every year. There are postgraduate students. We have 60 postgraduate students in our department. They've already lost now 2 months of training. They are only seeing COVID X-rays, and they are being posted in various parts for COVID care. How they will make up, when the exams will be held, when their thesis will get over, when their next lot will join, and
maybe Dr. Anshu, I guess barring like hands-on procedures, I would imagine that digital platforms would be the best way to go.
Yes, that's what they are doing.
With radiology, we are blessed.
Webinars.
Yes, so they should be useful.
Until you report yourself, until you to make mistakes in that, it doesn't happen, And that's for us, but for the rest of the hospital who actually have to, see patients, treat them, manage them. It's I don't know how our hospital will go, because I don't know when it will come back to a status of non-COVID or mixed or whatever.
Mixed, a normal hospital. Yeah, it's challenging.
We have one for our residents.
Yeah, we have one question from Dr. Asif Ibrahim. What precautions to take for routine ultrasound, as there will be asymptomatic carriers? I would request maybe Dr. Anju or Dr. Rafaela Basilico or Ram or anyone on the panel to address this, please.
Oh, can I answer? Okay.
Yes, please. Yes,
yes, the routine, the precaution we are taking now is our technicians are wearing PPE equipment, and goggles, even for each patient coming to the emergency.
Rafaela, could you turn on your camera, please? That way we can see you.
Okay, sorry.
Yeah, thank you.
Can you see me? Yes, okay.
Yeah, we can see you now, yes.
Okay, so because we do not know if we have to consider each patient as a COVID patient now. That's the problem for after the lockdown. And we recommend our technicians to wear gloves, masks, and sometimes goggles when they perform CT. And we try to disinfect CT room after each patient. The problem is for emergency department, because in this case we are
ultrasound is since more hands-on while you're doing the procedure. So what precautions are you taking while doing the ultrasound examination?
For the ultrasound examination, we wear the gowns, the gloves, the visor, the protective visor, and the patient has to wear the surgical mask. That's the precautions we take when we do ultrasound. And we, for social distancing, we are giving our appointments in 1 hour time interval from one patient to another patient. So we are we are still reducing our workflow. We cut in the past of 80%. Now I are starting to ramp up our examinations, but we are not in a normal workflow yet. And that's the problem, because we are in a very delicate, very, very challenging phase. It's the most dangerous phase, I think, now.
Yeah, you're right. Yeah, because now it's going to be a mixed population. Dr. Anju, would you like to tell us how you have done ultrasounds in your hospital? I know it's a COVID only, but I was reading, and perhaps one of the webinars that I attended, so they're using some kind of a shield between the patient and the ultrasonologist. So has anyone implemented that?
We haven't implemented that in our hospital. We saw it and thought about it, but then once it became only COVID, so now the person who is doing it is wearing a full PPE. But even then, I think it's a great idea to have that shield, because yes, this morning I was told that last evening one of my residents who did 3 consecutive ultrasounds in a PPE, one of them was a triplet pregnancy, so you know how long that takes. So at the end of it, he passed out. So, and because the AC was not working too well, so this is what happened to him. So
and these are the window ACs that you have now in your
yes, we have now established window ACs and are in the process change. There were central ACs in the whole of the emergency, and now there are window ACs and split ACs which have been put. And yesterday evening it was not functioning well, and this was a problem. So if we have a sheet like that, like similar to doing a sampling procedure, you take out your hand screw holes in the shield, and you can take your transmitter through that and do your ultrasound through that. Then you may not have to wear the complete PPE. You can do with a gown and a head cover and a mask only. So that would be very, very helpful, but we need to devise them, or we need somebody to start making them commercially. I don't know whether they are available yet in the market, but it would be a good thing to have.
Perhaps, Ram, I guess being a pediatric radiologist, you might have done a lot more ultrasound. What are the changes that you've incorporated?
Well, actually, my role was twofold within my hospital. I'll address them. I think it's a very valid question because quite a lot of our staff were concerned, and I talked before about education, alleviating fears, and members of staff unsure. We take our guidance from Public Health England in the UK and all the hospitals. It's a unified system where everyone follows. My default for anyone, of course, is always listen to what the WHO advises. The main concern of our staff was really long sessions and close contact with the patients. Most of them spent about 20 minutes per patient. And also the other concern was that they had family members at home. Their question was, are they allowed to use aerosol generating procedure PPE guidance as opposed to non-aerosol generating procedure PPE guidance? So in our trust, we have two separate guidance depending on the clinical situation, and ultrasound was deemed as a non-aerosol generating procedure PPE guidance, which means they wear a fluid-resistant surgical mask, they will wear a gown and gloves. And so, again, to get more information and evidence, I discussed this with our chief microbiologist, who also works alongside the infection control department. And he says, based on the evidence that they have, that what we have advised at Public Health England, which some may disagree, is sufficient for patient care. With regards to pediatrics, the key thing is, does the child need the investigation or not? Is it urgent or non-urgent? What we had done is we proactively canceled cases that were routine and say they will review them in 3 months' time. And all pediatric ultrasounds come directly to me for discussion. And there is a concerted effort to make sure that there's a consultant discussion on appropriateness of scan and will it affect management. It's not only about patient management, it's about patient movement. And the less we move patients around our trust, the less we risk exposure and spread of transmission. So again, the UK guidance from Public Health England may differ from the WHO guidance and from other countries. So I'll caution that by default, always go back to WHO guidance for any particular country if you are uncertain. I hope that is useful.
Yeah. Thanks, Ram. My last question, Arjun, it's for you. I was wondering, since you've been at the forefront of teleradiology, one of the pioneers in the country, and also been very active as far as telemedicine goes in general. I know the group has been doing plenty of it. So how do you see the Indian healthcare scene change post-COVID or during COVID? How ready are the physicians and the patients for tele consultations and teleradiology? Or if you have any other comments that you want to make.
Thank you, Anjali. That's a very interesting question you just asked, and it reminds me of a statement that a friend of mine made recently. He's a public health specialist, and he said it's like you have been preparing for a pandemic for the last 2 decades. He says, with teleradiology, you've been social distancing and you've been doing everything you can to deal with the COVID situation long before it ever appeared.
Funny.
So yeah, so that's kind of that's the whole thing with telemedicine and the situation where we find ourselves today. It's been around forever, but it's only in the face of today's crisis that we're seeing its resurgence, its emergence in some respects. Teleradiology, fortunately, has received its share of attention, but telemedicine has been long neglected. And on March 23rd, I think it was, when the Ministry of Health, Government of India officially legalized telemedicine. Before that, it was a gray area, and it wasn't very clear whether it was legal to do a telemedicine consultation or not. But on that day, everything changed, and the barricades opened, and suddenly a new era in medicine has dawned in India. So I think it's a very impressive decision, and it's taken at absolutely the right time. And I think it will, both from the physician and from the patient, there's sudden acceptance. Both sides had hesitation before, but both are embracing it now. And it's sort of like the restrictions on travel. When you don't have a choice, then you embrace the use of technology and you use video conferencing. So I think its time has come.
Thank you so much. I'm just going to take a few questions.
Sorry.
Yes.
I'd just like to.
Yeah.
Sorry.
No, go ahead.
I'd just like to add to Dr. Arjun, because this is a UK-specific experience that shows the strength of teleradiology and partnership between private and the government sector. We have a lot of UK radiologists who work for teleradiology companies and also within the NHS. The only caveat is you cannot work for your own hospital if your hospital uses the same teleradiology provider that you work for. But what happened was there was a national effort for all teleradiology operators to allow the hospitals to use their network to then connect with their own radiologists within that. So you would have a radiologist that works at that hospital that works for a teleradiology company, and the teleradiology company allowed that to happen free of cost. So that allowed a rapid deployment of teleradiology capacity using private industry to allow all the radiologists to work from home. And that was a remarkable achievement. I'm not sure how that would work in India, but certainly within the UK, that allowed a lot of our radiologists to be protected and at the same time to deliver the best care they could to the local hospitals.
Yes, thanks,
and
Go ahead, Arjun.
Sorry, if I may respond to that, Anjali. In the United States, the other thing, Dr. Ram, is that there are state restrictions on teleradiology and telemedicine. You have to be licensed in individual states. Now, what we've seen in the response to the COVID pandemic is that the states are relaxing some of these regulations. So they're allowing telemedicine to happen across borders with expedited forms of approval and credentialing. So, in an emergency situation, in a war situation, as you put it, we take extreme measures are called for, and I think that's what's happening everywhere.
I wouldn't say it's extreme. I think it's a sensible measure, Dr. Arjun.
Thank you, Arjun, for your comment. We have a question from one of our participants. After CT scanning of suspected COVID patient, when can the next patient be taken? Any time gap is required after sanitization? I request any one of you to take it, please.
Can you repeat the question, please, again?
After CT scanning of a suspected COVID patient, a suspected or a COVID positive patient, when can you take the next patient? Any time gap that is required after sanitization?
Within our department, I can answer that, at least from our department experience.
Yes, please.
So in our department, we just streamlined the entire process to affect all patients, regardless if you're COVID positive, suspected COVID, or no suspect COVID. The first thing we did in our CT department within the room is remove all unnecessary equipment. That would reduce surface area. We make sure we disinfect the room according to our local policy, and we give 20 minutes per patient. And we found that to be effective, at least for our own practices. But I think the key message is reducing unnecessary surface area. I think that in itself makes a huge impact on which droplets can
How much
adhere to.
time gap are you giving once the surfaces are cleaned up after a patient is
20 minutes. 20 minutes.
Okay, so it's
Yes.
20 minutes.
And that brought down the capacity to about 60%.
Okay, thank you. So another question, after ultrasound of patients, what cleaning protocol should be performed for the probe, excuse me, gloves and the bed in today's scenario? So after ultrasound of patients, yes, go ahead please.
If I can answer, now we are using only routine disinfection procedure. Just we disinfect the probe, the bed, and we change the gloves. So I agree with Ram. We have to eliminate any unusable items in the room, and then we just need to disinfect appropriately with the appropriate disinfectant for each probe, for each machine or each vendor, and the machine and the bed, and that's it.
So Rafaela, are you using any kind of covers for your ultrasound probe and the cable of the probe, or are you cleaning the entire cable also?
I'm cleaning the entire cable and the probe for each patient, yes. We are not using the covers.
We are putting some, we are wrapping the cables in a plastic cover, and then we remove it after the patient. If we have back-to-back positive patients, we don't need to do it between each patient, but after we finish the session, then we remove the covers. And we also try to put some plastic cover on the ultrasound console. I don't know how much it helps, but we do try to do that and then remove it at the end of the session. Also on the probe itself, we can put either a condom or a thing per patient that can be changed if required. These are just efforts, I think, to minimize transfer and make the patient, not the patient, ultrasonologist a little more comfortable, the whole thing.
Thank you. Just the last question now, as we sometimes keep old CT MRI films, since a lot of our hospitals are non-digital, for comparison or review, is there a risk of infection from these films? How to disinfect or sanitize the hard copies? So what do we do with COVID patients or suspected COVID patients who are getting their old films for comparison, hard copies? That's a huge challenge. I request any of the panelists to please, if you have thought about it.
All I can say is we don't use hard copies anymore.
Yeah, I know, Ram. Maybe Dr. Anju.
So it's really difficult to answer that question. I don't know if there's anyone else who might be able to help with that.
Keep it away for 2 days and then take it out and look at it.
But we are in an emergency setting, Dr. Anju. Doing emergency radiology. So.
Get your registrar to do it, not you. Get your registrar to hold it.
Nobody heard that. So, Dr. Sanjeev, sir, would you like to address this question and give the closing remarks, sir? So we can't hear you, sir. So we are unable to hear you. Dr. Sanjeev Sharma.
Yes.
Can you hear me now?
Yes, now we can hear you.
Very good. So this is, at best, this is a very unorthodox question. Perhaps my take on this would be to avoid reviewing these films as far as possible. If they have to be, they should perhaps be segregated to an office area which is not infected or which is not in the emergency zone. And if God forbid it comes in that area, as Anju said, 48 to 72 hours is what you would want to keep it aside to make sure that on plastics, these viruses, they would generally go away in 24 to 48 hours. So that's what we would do. But it's an unorthodox question because we don't use hard films, we don't make hard films anymore. So it's very difficult. It's not
excellent questions, are very pertinent. Yeah. I wondered if we should, check with the trade people and find out industry.
It will be a good idea. It will be a good idea. Exactly.
What they would suggest.
But above all, actually, this epidemic is teaching us to constantly, on a daily basis, analyze, adapt, and evolve.
Absolutely.
On a daily basis, we are having updation of knowledge and skills, and new issues and challenges keep cropping up. But our ability to evolve on a daily basis is the way we are going to defeat this challenge. That I think the last 1.5 hours or so, that this is pretty much what has what it summarizes. If I were to in one line.
Yes, thank you. Yes.
There is one question which has come up just now. Anjali, there is one question which has come up just now.
I see that. Any chance of to spread with handling of a prescription? I guess it should be the same as, handling paper.
Oh, no, only thing is with paper it is much less actually, because on paper it doesn't survive for too long. So maybe 4 hours or so is about all that you need to put it away.
So no, we have an answer. Look at it. Make sure you wear gloves, because now you will have mixed patients. So that's a good idea. When you are picking those films, you're well gloved.
But we've had a wonderful discussion actually on the management of radiology departments as a whole, whether this the equipment, the staff, what's that? Do you consider FNAC well? It depends on what kind of anesthesia that is being used and what location the FNAC is. But FNAC can be an aerosol generating procedure depending upon the location and the type of anesthesia used. So you have to address this appropriately with the designated PPE.
And I think can I say something, Anjali, before we come to a close?
Yes, Ram, please, yes.
Well, I'd like to say, as usual, you've always organized an amazing panel discussion. I'd like to thank, again, the Society for Emergency Radiology of India, and of course, you from Telerad Solutions, for organizing such an amazing panel. As always, again, echoing what Professor Sharma said, it's constant learning and staying ahead of the game. And I found it very useful to be able to listen to all of you share your experiences. So thank you very much for that.
Yeah, thank you. I want to thank all the panelists. At the end of the day, we have to be prepared for a marathon. We're not running a sprint. COVID is here to stay for a very, very long time. So I think thank you all for joining us, all the panelists for sparing your valuable time and logging in and sharing your experiences. Thank you.
Thank you, everyone. It was enjoyed us. Yeah.
Thank you very much.
Thank you. Bye-bye.
Thank you.
Bye. Bye-bye.
Bye.
Bye.
Put it in perspective. It's over. It's okay. Anyway.
Yes, sir. So you were saying something?
Oh yeah, I was just wanting to say this, that on behalf of the Society of Emergency Radiology, I think we must put in place our gratitude and thanks to all the panelists for this wonderful job. And it was very well attended actually. I could see over 70 participants at one stage. That's very good.
Thank you to you.
Thank you very much.
Thank you. Bye.
Thank
you very much.
Thank you, everyone.
Bye.
Thank you.
Bye.
Bye.
Bye.